Thank you. And this meeting is being recorded, just FYI, because we're going to put this recording on our website, but we will be turning the recording off before the Q&A in case you have anything personal to share. So our agenda for this evening is to start off with a quick overview of the work that we've been doing between the UVA STAR Initiative and Thomas Jefferson EMS Council to develop and disseminate autism training for first responders in the Central Virginia region. We're then going to spend most of the time over the next hour sharing tips for successful first responder interactions that we're sharing both with first responders and the autism community. And then, as mentioned, there'll be some time at the end to share questions and feedback. Before I jump in, I did want to share the disclaimer that understandably thinking about crisis scenarios involving someone with autism, having interactions with first responders can be stressful to think about. And therefore, if you yourself have been personally involved in such an interaction, these may be topics that might be difficult or stressful for you to think about or for your peers on this call to think about. Many in the autism community that we've spoken to and that we've met as we've been doing this work have had differing experiences and perspectives on emergency response. Some have had very positive experiences, some have unfortunately had negative experiences. So we invite you to be cognizant of that and respectful of maybe hearing differing perspectives on the meeting or on this call today based on everyone's individual experiences and background. If you would like to share but feel uncomfortable, we invite you to also take the time that you need to before sharing. And we also will be sharing our contact information at the end of the presentation in case you'd like to reach out individually at a separate date. To kick us off, I wanted to emphasize why this is such an important topic to be thinking about for the autism community. And the odds are, if you're on this call, you probably are aware already. But we know through research that people with intellectual and developmental disabilities, including autism, have been shown to be 7 times more likely to come into contact with emergency responders than the neurotypical population. Some other research has shown that by the time they reach age 21 years, autistic youth have on average about 5 experiences with first responders. Again, this is by the time they reach 21. So this is quite a substantial risk factor and is likely to have a significant effect on the person based on whether those experiences go positively or negatively. We also know that there are significant risks for negative outcomes faced by the autism community, and some of those dangers are situations in which first responders play a critical role. We know that people with autism are at increased risk of elopement, particularly children or adults who have co-occurring intellectual disability. And wandering tends to be a precursor or a risk factor for significant injury or death. On the screen, there are faces of 6 children who in the last few years have unfortunately passed away following an elopement incident or a related incident such as falling out of a bedroom window. These are all situations that require emergency responder interaction or response to help save lives. So as a result of this, it's critical that first responders have a clear understanding of what autism is, what it looks like, and how to successfully interact with autistic people to help promote safety and positive outcomes. So the goals of this current work are motivated by these risks, and they stem out of the local community in Central Virginia. We were approached at UVA a few years ago by a local advocacy group requesting that we start working with local first responder agencies to deliver training around emergency response and autism. And through that work, we learned that progress is difficult in these areas because there's a high amount of turnover amongst first responder agencies, which means we may build capacity in autism, but then that capacity may go away. There's also inconsistencies across autism trainings that are out there, and they range in terms of evidence base of the information that they're sharing. And we also have found that we need to figure out ways that we can make these training approaches sustainable so that, as I mentioned, they continue to be offered year after year, even if originally trained responders are no longer with those agencies. So we've developed a few different projects from this work. We've developed an autism response training that really focuses on how to educate first responders on autism and promoting those successful interactions. We've developed an autism response guideline, which has been approved for use by the Virginia Organization of Emergency Medical Services. So it's approved for use by emergency medical technicians who respond to a scene when there is a medical concern. And we're also working on developing various avenues through which we can share recommendations and tips around emergency preparedness with the community and by that I mean autism community, such as the presentation that you're attending right now. As I mentioned, a big piece that we're trying to emphasize with this work is evidence-based information being delivered to people, first responders, about autism. So what we've done is we've done a review of the research literature around this topic. We've also talked to key community stakeholders, i.e. autistic adults, caregivers, as well as first responders themselves, to figure out what should first responders really know about autism, what guidelines can we generate from common themes to develop such education, training, and protocols. So now I'm going to briefly review what those key findings were from all of that work, just so you have an idea going forward. Should you consider a 911 call or making a 911 call or request for emergency support, that this is the content that we are training first responder units in the Central Virginia region going forward. So some common themes from the work that we've done really revolve around the idea that all responding units, i.e. law enforcement officers, emergency medical technicians, firefighters, fire rescue officers, 911 dispatchers, all of these professions need to really be on the same page. And to date, many in the autism community have reported that they typically haven't been. Typically finds that they have to repeat themselves multiple times to different officers and responders as they arrive at a scene, that people come in with varying understanding of autism and patience and understanding. And all of this contributes to highly variable experiences on the side of autistic adults and families of people with autism. And as a result of that, we've heard from many people that they generally tend to call 911 as a last resort option because they're really just generally uncertain about what response approach they're going to get. So that's a big piece that we're trying to drill home with first responders at the moment, is that you all need to really be on the same page due to this level of mistrust that's been built up over time. We're also focusing in on the uniqueness of autism, sharing how autism may be really different from one person to the next, really focusing on understanding what the person's communication style is and how to facilitate communication, soliciting input from the person themselves or their caregivers if they are at a scene to help guide a response approach, understanding the person's special interests or hooks that might help calm them down or help even help first responders find someone if they've eloped from home or school, using patience, and also being very aware of and working around sensory aversions and preferences. We're also talking a lot in our trainings about more autism-specific reasons for 911 calls. Of course, there could be any reason in the world that 911 support might be needed, but these are calls that might be more common for people on the spectrum a mental health emergency. That can look like a meltdown or a behavioral outburst. It can also include wandering or elopement. And then medical emergencies may be more prevalent due to unique needs or unique profiles of needs, such as increased instances of gastrointestinal issues, epilepsy, and other co-occurring conditions. We also talk a little bit about understanding that due to very literal thinking or concrete thinking, some autistic people may have learned as survival skills or self-care skills that certain very black and white things, like if you see blood, that's an emergency, call 911. They may be called to a scene where that is the case, that is the experience, which is examples of some stories that we heard through our research. And then understanding how to communicate with and work with the individual to honor their perspective and that anxiety they're having, but also help them calm to understand that it's not an emergency event that would require going to the hospital or something else like that. And then we also talk a lot about training needs, specifically triggers for 911 needs and de-escalation strategies that would be helpful in response to some more common triggers that are more common to people with autism. So extreme sensory inputs, for example, being in high demand, overwhelming situations, communication breakdowns, etc. We're also really driving home the idea of involving input from the advocate, whether that's the person themselves, a caregiver, a professional paid staff member who's at the home, and trying to consult with them as much as possible first thing upon arrival or prior to arriving there if the person is on the phone with a dispatcher. We're also really focusing on teaching responders that caregivers can give really important cues on how to respond to someone to help de-escalate them. Finally, a big part of what we're emphasizing is how to improve the experience for the next time. So making sure that responders check in with the person, the caregivers, after a call to see how it went, to give them resources that they can use to improve their emergency preparedness for next time. We're also teaching responders to go back to their home agencies, reflect on how ready were we as an agency for an autism call? How can we be more ready next time? And then, as mentioned, sharing a lot of resources above and beyond what we share in the training so that they can continue to share those back with people on the spectrum, their families and agencies or other responding units to facilitate that improved response. Just to give you a quick idea, this is a pictorial, a prettified version of the autism response protocol that we've developed. We've developed the acronym SOCIAL to help responders remember these key strategies and hopefully internalize them a little bit easier. And they stand for, again, 6 core themes that we were able to pick out out of all of the information that we gathered from key stakeholders and the research that we did. So understanding what the person's sensory needs are, preferences, aversions, turn the flashing lights off, minimize sirens, streamlining communication rather than law enforcement and EMS and firefighter all approaching the person or a caregiver individually, choosing one communicator and facilitating a more streamlined communication approach to minimizing that state of overwhelm. Using clear and confident and calm communication with someone on the spectrum to help de-escalate them if they are in an escalated state. Using interests as tools, potentially looking for someone where they may find the source of their interest if they have eloped, for example, a comic book store, Walmart, the nearest lake if they have an affinity towards water, involving advocates as much as possible. And then again, that quality assurance piece of looping back with the person, the patient, if this is a medical emergency, their family, and then home agencies to facilitate improved performance during the next autism call. Our next steps is between now and December, we will be offering this training to law enforcement, emergency medical service teams, fire rescue agencies, and 911 dispatchers within the Thomas Jefferson or Blue Ridge Health District, which includes the counties that you see on the screen, including the city of Charlottesville. We've developed a hybrid online and in-person training, and we're also incentivizing completion of this training by having gained continuing education credit approval for this program for these professions. So we're really excited to see the number of folks that will sign up for this, and scheduling is actually starting as of about 12 hours ago. So we're excited to see how that goes. So for the rest of the session now, I'm going to be describing strategies that we have learned about along the way that have been recommended to us from autism families, from people on the spectrum, from first responders, on how you, as maybe someone directly connected to autism, can prepare for that next emergency or crisis situation. One question that's has come up a bit in our conversations is better understanding the speed with which responders will arrive at a scene, and the speed with which, or the logic behind, when first responders get hands-on. And this has been something that's been particularly concerning for parents and autistic adults because of that concern of that quick hands-on approach potentially escalating someone even more. So while we do not have the capacity to change core guidelines that responding units have to use if there is a suspicion of an emergent medical need or imminent risk of harm, what we are doing with that is educating responders more around understanding what behaviors may look like and not look like, so they can better interpret if this is a true emergent situation or if this is a true threat situation, and think a little bit more before jumping to an aggressive hands-on approach. With regards to medical responders, their guidelines are that if there is an emergent care needed, i.e. someone is bleeding, they have been shot, there's something clearly very seriously medically going on, responders they are required to act quickly. They may need to jump in before permission to touch is granted. In these situations, they've been trained to provide a lot of reassurance and praise to the patient to help try to keep them calm or get them to calm down. If there's a non-emergent, urgent or non-urgent care needs, so there's something medically going on, but they are not at significant risk of excessive bleeding or potential death, then providers will arrive and they will typically ask to touch first, and they're more likely to do use procedures that we're really drilling home as being helpful, including an explain, show, do approach, as in first I'm going to tell you what I'm going to do, then I'm going to model what I'm going to do, and then I'll do it, giving the person ample time to prepare themselves. And this is a big part of our training as well. Another special consideration is use of restraint. Across units, whether it's law enforcement, medics, emergency medical technicians, they are trained that these should be used as last resorts after all other strategies have failed, or if the person is unable to calm. There are different types of restraints. The technical terms are on the screen: mechanical restraint and chemical restraint. Mechanical restraints include handcuffs, which are used by law enforcement, or soft cuffs that emergency medical technicians may use to help immobilize someone while delivering medical care. Chemical restraints are one-time use sedating medications to get someone to calm. These are not used until a senior medic has been consulted, so they need to be arriving at a scene and consulted. Emergency medical technicians, the ones who typically arrive, cannot implement these medications on their own. And they are required to consult with the family regarding what PRN medications or daily medications the person takes before administering such a medication. The reason I'm telling you this is that if you feel like your experiences does not go along with these guidelines, then I encourage you to reach out to those agencies or other contacts, and I share contacts at the end of this talk to share what you've seen, what you've heard, so we can follow up. There are a number of resources out there that are also helpful to complete or download or access today if you think that you yourself or someone in your family or a loved one is at risk of requiring 911 support in the future. The first of these is a wellness recovery action. There's a link on the screen there on how you can access these. You can also Google Wellness Recovery Action Plan to find the website and templates. This is actually an evidence-based practice that has been developed by the Substance Abuse and Mental Health Services Administration. It's an evidence-based approach, meaning it's been researched quite extensively and found through research to significantly improve a number of health outcomes in people who use them, including reduced psychiatric symptoms, increased hopefulness, increased quality of life, increased empowerment and self-advocacy skills. They sound like some very extensive, elaborate process, but what they actually are a really nice toolkit that you as an autistic person or someone who supports someone on the spectrum can sit down with and think through and map out each step in that crisis cycle and how you can help support and prepare for that crisis. So it has you think through what times when the person is calm, what keeps the person calm, what keeps them safe, and really identifying in a concrete way what those strategies are. Then thinking about the next step. What are those pre-crisis signs? What are the rumbling signs? What do they look like? What are some strategies that you can use to help de-escalate at this point? What are some things that the person can do themselves to help themselves calm if they start to show those rumbling signs? And the same process through each stage of crisis, from calm to full crisis mode and then recovery. And what we found, or what we as a global sense have found, are that really articulating each of these stages and strategies that can be done helps make the person more aware and more aware of these skills and more likely to follow through and implement them pre, during, and after crisis to help promote that well-being. I'm going back a slide because I want to talk about these next two strategies as well. Thanks to advocacy from my partner, Pepper, all Central Virginia counties now use a premise registration form. What that means is that emergency call centers in all Central Virginia counties have a form that you are able to complete to register someone as having autism with your phone number or your address. On top of that, you can share key information like risk factors. This person is at risk of elopement. This person really doesn't respond well to sirens, other key information like that, so that when you call from that number or that address, the 911 dispatcher can pull that information up immediately and share that with dispatchers. So that is now a form that's available within all Central Virginia counties. Sometimes they can be a little bit tricky to find. In Albemarle, Charlottesville, for example, they are available on the charlottesville.gov website. If you have a hard time finding it, feel free to reach out to us or call the non-emergency line in your area and they can help you find it. But we highly recommend completing and submitting this to help, again, provide that information ahead of time. We also recommend that you connect with your local agencies to introduce your loved one on the spectrum to responders in uniform, show them that there's a friendly face behind that uniform, help the person desensitize to trucks and those loud cars, so that the whole experience becomes slightly less overwhelming. And this is actually some work we're starting to do with the local autism school buyer, to have first responders go out and meet with students there, so that they can themselves can start becoming more familiar with people in uniform. As you are making a 911 call, you're considering making a call, understand that dispatchers are trained to go through a particular decision tree with their questions. So they may not always ask you some of the key information that you will want to share. As a result, it's important to remember to share this as soon as you are able to get a dispatcher on the phone. So examples include whether this is a non-critical or a life or death situation, which you're most likely inherently will share, but remembering to articulate how critical it is, if you need help de-escalating, and if so, how long has this outburst been going on, if you are responding to an outburst, so that they are aware of how long the person has been in crisis. First responders have shared with us that the number one thing they always want to know if they're responding to an autism call is, what is the person's communication ability? Are they nonverbal? If they're nonverbal, how can we communicate with them? How can they respond? Understanding if they script or use echolalia, those are terms that we are teaching them as well. You are able to request a staged approach, which is an approach where responding units, rather than arriving all at once, creating this loud outburst of noise and light and sound, you can request that they arrive one at a time to minimize how overwhelming from a sensory standpoint the whole interaction is. You can also request a autism or a CIT trained officer. CIT is an accreditation that law enforcement officers can complete that's really focused around mental health, and they include some education around developmental disabilities. CIT. There are also resources that you are able to purchase or access for free through local organizations like Project Lifesaver, that you can use to help identify autism for a first responder. The caveat with this is that a lot of autistic people that we've spoken to feel very variable about whether they want to self-disclose their autism to first responders at the get-go. One thing we encourage autistic adults to consider is that understanding autism as they arrive on the scene may help that responders tailor their approach a little bit more sensitively. And we also talk about some of these resources that can be used that can identify autism in a more subtle way. So, for example, ID bracelets and wallet cards can be used. An example you can see in the top right-hand corner of the screen. Virginia ID cards and driver's licenses now come with can come with an autism designation on them if you request it. And this is something, again, that has received mixed ratings in the autism community, self-advocates, because again, there's that stigma that may inherently come with having that labeled on one's ID, which is understandable. What we like to point out with the ID is that it's listed as the small 9 restriction code on the front of the ID, and on the back they have a little code that identifies 9 as ASD or INTD for intellectual disability. So it is more subtle, and generally people don't look at it unless they know to look at it. But again, this is up to the person themselves if they want to include this on their ID. Cars can have a lot of different identifiers added to them, including alert stickers to be viewed by first responders. And I said this wrong on the last time we did this presentation, but these typically are put on the back car window and the passenger side window. And Stephanie, jump in if I said that incorrectly, but these can be used to identify someone in the vehicle as having autism. Thank you.
I think it's on the side that the officer approaches from. So okay. I think it's the left.
The driver's side.
I don't know.
Okay.
Yeah, I'm not sure. That's what I thought, but sorry.
Okay, that does make sense that it would be on the driver's side, but there are stickers available nonetheless. Thank you for correcting me on that. You can also access other resources like buckle guards or harnesses, which can also be helpful for responders identifying someone as having a developmental need in the car if they see these. In terms of preparing for a 911 call, if someone is at risk of being taken to a hospitalization, there are a few other resources that you can download, access, or prepare. And we do have links to resource folders and packets, including these materials that we'll share at the end of the presentation. But one thing we recommend is preparing a worksheet with key information about the person to be included in their wallet, on their person, or in their bag if they are at increased risk of requiring a hospitalization, having a current medication list updated and ready to go, and again on that person, on their person or nearby, and then to-go bags ready either in a car or at home if they are at risk of being taken for a hospitalization. There are a lot of examples of About Me pages online. We'll share some examples with you, but if you look them up or if you search on Pinterest, you can find a template that you perhaps like. We recommend that you include information on there about the person's communication ability, their likes, their dislikes, and some of them even have helpful aids on there at the bottom, like you see here, that may be useful to include only if the person actually uses this form of communication. Medication lists, as I mentioned, are important to include, and understanding certain triggers or certain risk factors like maybe attracted towards bodies of water, pica risk, other things like that. In addition to preparing to-go bags, if hospitalization is a risk, some of the resources we've also looked at have recommended having emergency disaster kit ready or having an emergency disaster plan for those more serious scenarios. Here's a list on the screen of some materials that might be good to include in that. It's also a helpful link on the screen of how to think more concretely about disaster planning if you're planning for a loved one on the spectrum. Here are some safety packets that Stephanie has compiled. You can access the first one through tinyurl.com/safety packets. It includes several of those forms I've mentioned so far, as well as emergency planning guidelines. It also includes the National Autism Association's First Responder Toolkit, as it includes a lot of really good information about finding missing persons on the autism spectrum that you might want to just have on hand to facilitate that preparedness. We also recommend some other packets that are already out there, including some materials developed by Autism Speaks, safety products and safety services lists. Safety products examples include those identifying wristbands or car stickers. It also has some resources on there that might be helpful for families that are affected by wandering. Safety logs, for example, can be completed if you're trying to figure out the frequency or risk factors or predictors of wondering if you're not quite sure what's going on there yet, you can use their template safety log. It has a really nice template letter that you can share with your neighbors to share information about someone in your family who may wander or is at risk of wandering and what to do. It has template wandering plan in there and safety FAQs. The Big Red Safety Box toolkit is another really nice form that you can fill out and have ready to go if you believe that you may need to call 911 in the future to respond to someone having gone missing from your home. That has an elopement alert form that has specific information, or it'll have you fill out specific information that's particularly relevant to a wandering scenario that you can again hand to a first responder. The reason I'm really drilling in filling these forms out and having them ready to go is because of course, the situation when you're in a high stress situation of needing to call 911, you've potentially been trying to de-escalate someone for a long period of time, you're very anxious because someone has gone missing, you're not expected to remember all of this key information. So as much as you can have this thought out already and ready to go, the easier you'll make it on yourself to be prepared for that next potential crisis situation. Stephanie's also developed some really nice PDFs, including the safety prism and popular topics that includes links to resources across the lifespan that are relevant related to emergency planning. One of the last things I recommend is understanding your rights and responsibilities as a patient, again, related to hospitalization, or as a community member, if someone you know is at risk of being incarcerated or taken to a police station. With regards to hospitalization, Virginia law states that if someone has a documented disability, they are entitled to have a caregiver come with them to that hospitalization. So oftentimes families are very worried about the idea of calling 911 in case their loved one is taken to the hospital and then they're separated from each other and the caregiver is unable to advocate for them. You do by right have the ability to go with them to that hospitalization. If you are at the hospital and you feel like you're not being listened to, if you feel like you're being pushed out of the hospital, you have the right at that point to request a patient representative to help advocate for you or your family members' needs. If that doesn't work, you can make complaints. You can contact the hospital. You can contact the local Emergency Medical Services Council. You can also contact the Virginia Department of Health. And we encourage you to do this because the more voices that are out there to say this isn't working, the easier it is for us to advocate for improvements and reform around some of these policies and procedures. Rights related to service animals are that a service dog that is that someone has for an identified disability or to help someone perform a function related to their disabilities by right have to go with the person to the hospital or to the police station. They can be transported in an ambulance. I don't think they can be transported in a police officer's car, but perhaps someone else can bring the dog to the person at the police station. Also familiarize yourself with Marcus Alert. This is a relatively newly impacted policy that is all really focused around the idea of improving a coordinated behavioral response between law enforcement and regional crisis call centers such as REACH to help send someone trained in mental health out to a 911 call to respond to someone in crisis after they've been taken to a hospital to help support the individual. This is newly enacted, so it's not fully in effect in all regions of the state yet, but it is something that there's a lot of work happening to help make this more widespread. So, and in the spirit of that social acronym I mentioned to you, looping back, we're encouraging first responders to loop back with autism families, with people on the spectrum that they meet, to give them resources for next time. We're also asking you to loop back, contact the 911 dispatcher at the emergency line to give them feedback on how that call went, if you had a difficult experience, or if it didn't go well, or if it went well, so you can share that feedback with them. You can also contact our team at the EMS Council, tgems at vaems.org, or starresearch@virginia.edu, and we can help you get your information or your feedback to the right person. Here on the screen are a few additional resources related to emergency planning. We will share these slides with you after tonight's presentation, which will include links to all of those resource packets as well, should you like to look at them or review them. Finally, we'd like to acknowledge the support that has been given to this project by a few different funders and key organizations, including the National Center for Advancing Translational Sciences, UVA Jefferson Trust, and the UVA School of Education. We'd like to acknowledge and say thank you to our project team, including Stephanie and Keith and others who are not here tonight, but also our 3 instructors for this program going forward, Shannon Fry, Brendan Oakes, and Rebecca Kilmeyer, who are a combination of self-advocates, first responders, and autism parents. We're excited to have them taking over instruction of this program. And finally, we'd like to acknowledge and say thank you to our community partners, including CRAG, VIA, and Legal Reform for IDD, who have done a lot of important advocacy work in this area to help get this work off the ground. So I'll end there, and we have about 15 minutes for comments, questions, concerns. I will leave my screen up for a few minutes so that you can jot those emails down if you'd like to. But if anybody has any questions,